Time for another Puscast, a review of the infectious disease literature covering the last 2 weeks of August in the year 2018. References, as well as links to my growing multimedia empire of books, blogs, apps, and podcasts can be found at edgydoc.com. Otherwise, not much to tell you, so let's get on to the literature, shall we? Pre-exposure prophylaxis works. Those who use it almost never get HIV. The problem is that no good deed ever goes unpunished, and this study looked at the consequences of PrEP, pre-exposure prophylaxis, in men who have sex with men, and found that condom use declined, and consequently an increase in both rectal chlamydia and other sexually transmitted diseases went up. And not unsurprisingly, as time went on and people became convinced of the efficacy of PrEP, condom use went down and STDs went up. Not a surprising consequence of pre-exposure prophylaxis, but an important one nonetheless. Interesting article on the epidemiology of hantavirus in China. They have the hemorrhagic fever with renal syndrome, predominantly by the Hantan virus and the Sol virus. And they looked at the characteristics of this disease over a 48-year-long period and found that initially, as cities became increasingly urbanized, as the farmers moved in to areas of often suboptimal living conditions, i.e. early squalor of urbanization, that hantavirus infections increased and the rat populations increased. But that over time, as the cities became even more urbanized, the health of the population improved, the rat population, presumably decreasing, found a decrease in hantavirus in China. I tend to think of hantavirus in the United States as predominantly a rural disease, as cities and humans encroach onto what was wild areas, they become exposed to mice and subsequently get hantavirus. That's different in China, where migrants or immigrants from the rural areas would move into the cities. There would be bad conditions, exposure to rats, and subsequently outbreaks of hemorrhagic fever with renal syndrome. That only improved as living conditions improved. An interesting, different epidemiology. I don't know. Statistics always makes my head hurt. I feel like Mr. Gumby from Monty Python. The study looks at the association between anti-CMV immunoglobulin G and neurocognitive performance on heart of AIDS patients. And they found that the higher the anti-CMV IgG levels, that there was association with worse neurocognitive performance, but that p-value was only 0.059, which means it probably is not significant. I remain convinced, although I can no longer explain coherently why, that you have to have a p of at least 0.005 before you probably have something significant. In mucking around with the data, they found that this was only true in patients who were on heart. When you look at the number of parameters, they had about 40, maybe 35 different parameters, of which they found 3 or 4 that were statistically significant by the Crislip standard. And so when you look at the paper with my flawed understanding of statistics, you really wonder if this was a true finding or not, or just a variety of p-hacking. And when you look at the flaws in the study, as noted by the authors, that they did not have an HIV uninfected control group, they didn't measure anti-CMV IgG in the CSF, they didn't look for other herpes viruses that can reactivate, I gotta kind of wonder if this paper was, to quote Shakespeare, all sound and fury signifying nothing. Or maybe it is a deep and profound insight into our understanding of neurocognitive decline in HIV patients, and I just can't see it. Because I'm the Mr. Gumby of infectious disease statistics.
My brain hurts!
We don't have smallpox anymore. Well, hopefully there's none left in the world. Perhaps in a United States or Soviet biotechnology freezer. One of the consequences of no more smallpox vaccination is there may be an increase in monkeypox. But there are other pox viruses that you have to worry about. There's not only monkeypox, there's camelpox and buffalo pox and cowpox, and there's a unique pox reported out of Italy that is found in rodents and was subsequently passed on to a cat who died of this particular orthopox virus. And there may have been some orthopox transmission in the past from cats to humans. And apparently every animal has its own pox virus. It will be interesting to watch what happens over the next 20 or 30 years as immunity wanes in the human population, of those of us who have gotten the smallpox vaccination die off, and the human population becomes increasingly non-immune to pox viruses. If we start seeing more animal to human pox and, God forbid, a zoonotic pox deciding to do the old HIV trick and become adapted to human beings. The good news about this one is so far it only kills cats. Now, if I could just get one that would kill off the neighbor's barking dog. New Borrelia keep being discovered all the time. There's one, Borrelia caliharica. I assume. They don't, of course. I'm going to bitch again. They don't have a pronunciation guide. Actually, I also didn't know some of these Borrelia have the word candidatus in front of them. There's Candidatus Borrelia caliharica. Why the candidatus? What does that mean? No one's ever explained that to me before. So I Googled it, and if you probably knew this, but I didn't, but I'll quote the Wikipedia. In prokaryote nomenclature, candidatus, Latin for candidate of Roman office, named for the white gown worn by Roman senators, is a component of the taxonomic name for a bacterium or other prokaryote that cannot be maintained in a microbial culture collection. It is an interim taxonomic status for a yet-to-be cultured microorganism. No one's ever explained that before because, of course, they never include that in the articles. But this particular Borrelia species from Africa caused a relapsing fever that was tick-borne. That is in and of itself interesting, but now we all know why they put candidatus in front of Borrelia caliharica, if I pronounce that right. I think Borrelia are multiplying faster than Rickettsia in terms of new organisms being found. And as long as we're on the topic of Borrelia, they've been sampling the ticks in the Tennessee Valley of Tennessee, and they're finding that there's now Borrelia burgdorfii in the ticks, which is an increase. So it looks like Borrelia is moving into Tennessee, probably because the rents are lower. Elizabeth kingii, named after Elizabeth King, is an organism that has been causing outbreaks. There have been 2 outbreaks in human, one in an ICU in Singapore, and the other was in the community, Wisconsin, Michigan, and Illinois of the United States. They think it's been waterborne in the Singapore outbreak, although they never quite figured out the source of the Elizabeth kingii in the U.S. The organism has also been isolated from the midgut of the Anopheles gambiae mosquito. There's now been another outbreak. This one was in Singapore, and they found it in the tap water. And ironically, it felt that it was spread by hand hygiene, that people were washing their hands in the contaminated water and then spreading the Elizabeth kingii around. So at least 2 of the outbreaks of Elizabeth kingii infections have been associated with water and waterborne. This one, ironically, with hand hygiene. I think that would classify as true irony, unlike the song Isn't Ironic. Or maybe I'm wrong in my understanding of irony, as I am with my understanding of statistics. Some news in the Neisseria world. Eculizumab is a monoclonal antibody that inhibits the terminal attack complex of complement and is used in paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome. The consequence of this, though, is it makes people act like they have a terminal complement deficiency, which increases their risk for Neisseria infections. And they report a case of Neisseria cinerea bacteremia in a patient on eculizumab. In pronunciations. Also, they looked at the outcomes of meningococcal disease in New York City over an 8-year period, found that females were far more likely to die of meningococcal disease than males. And then finally, there's been a single clone of type W Neisseria that has been spreading across the world, first in Europe and Australia, and now it's found in the state of Georgia in the United States. It's my understanding that when there is an immunologic niche to fill because of vaccines that other strains will move in. I can't see that this particular strain is covered by the vaccine or not. They don't comment. But if you go to Georgia, hold your breath. We really want to go to Savannah next year and kick around. That part of the South has great food and interesting scenery and history, as long as you avoid the alligators. And one reason to hope that your cat gets an orthopox infection, there's a case out of Texas where the patient came down with both transverse myelitis and Guillain-Barré as a complication of a Bartonella Hensley infection. And they note the 4 other cases where cat scratch was associated with myelitis and another where it was associated with Guillain-Barré. Odd case, but a lot of people have cats, aka the other white meat. And when was the last time you checked a patient for cat scratch disease when they had Guillain-Barré? So keep it in the back of your mind. A hodgepodge of endocarditis papers this week or two. One was a review of a whopping 51 cases of prosthetic valve endocarditis due to Propionibacterium acnes. I've seen a grand total of 2 in my career, and they suggest that benzyl penicillin would be the treatment of choice. A study out of Taiwan to suggest that dental work does not increase the risk of endocarditis. But another one out of the United States that suggests that routine procedures done in the outpatient setting may increase the risk for endocarditis. And they put the relative risk as follows: gastroscopy 2.5, colonoscopy 2.89, dialysis 4.33, bone marrow puncture 4.33, coronary angio 4.75, bronchoscopy 5, and transfusion 5.50. Currently, none of these procedures are recommended for antibiotic prophylaxis. But it is interesting to note that endocarditis may occur more frequently after procedures, not dental work, than we suspect. A series of case reports out of Vienna where they treated endocarditis with dalbavancin with good success, 92.6%. But it was not used for primary therapy, but instead it was used for follow-up therapy after the bloodstream was sterilized. So was it the dalbavancin or was it the previously received endocarditis therapy? And finally, an interesting study in the New England Journal of Medicine where they looked at the treatment of endocarditis with oral therapy. Initially, patients received IV until about day 17, and then they were randomized to receiving either oral therapy or IV therapy. And they found the outcomes to be the same. The bulk of the organisms in this were Streptococci, Enterococcus, and Staph aureus. It is important to remember the number of patients that were excluded. They looked at almost 2,000 patients, but excluded 1,554 for a wide variety of reasons, including the etiology of their endocarditis, ongoing fevers, high inflammatory parameters, and other issues. As best I can tell, these were all rock-solid humans immunologically who responded immediately to their endocarditis and got better really fast. They were then switched to oral therapy and did just fine compared to those that completed the IV therapy. There's this interesting literature from the 1950s where they treated streptococcal endocarditis with oral therapy with actually relatively good outcomes. As I remember it, 80-90% of patients were cured with oral penicillin for their susceptible virulent streptococcal endocarditis. And I have cured strep endocarditis with a grand total of 2 doses of ceftriaxone. I had a patient who came in with emboli, bicuspid aortic valve, vegetation on his valve, grew a susceptible strep viridans. After 2 doses of ceftriaxone, he remembered he was a Christian Scientist and left. He came back to the hospital 6 months later or so to let us all know that God had cured him. I still think it was the 2 doses of ceftriaxone. So personally, I would have no problems, or few problems, in treating a streptococcal endocarditis with oral therapy. I would still be a wee bit leery about doing it with either a Staph aureus or an Enterococcus. especially since, at least with my enterococcal endocarditis, I've never seen a rock-solid, immunologically normal person who responded immediately to therapy and had no complications. I wonder where they found those patients. And interestingly, the majority had their aortic valve involved. And I get real nervous treating aortic valve endocarditis, having seen a number of these valves fall apart in the middle of therapy over the years. So I kind of file this in my "this is what you can get away with if you have to" paper, rather than what I would do with standard care. You can get away with a lot, but that doesn't mean it's optimal therapy. And then you have to weigh it against the risks of prolonged IVs, etc. So who knows what the right answer is. So I file this away under the interesting papers, but I don't think it's going to affect my practice much. And I'm still unlikely to give dalbavancin to anybody. A couple of C. diff papers. One, do probiotics prevent C. diff? Yet another meta-analysis, this one in JAMA, suggests, quote, moderate quality evidence suggests that probiotics are associated with a lower risk of C. difficile infection, which is consistent with other meta-analyses. But are they safe? We really don't know. Yet another analysis, this one in the Annals of Internal Medicine, concludes that harm reporting and side effects are lacking or inadequate, and we really do not know if giving probiotics are safe. And then perhaps the final nail in the coffin of metronidazole for C. difficile, this study published in the Lancet looked at the comparative efficacy of a variety of treatments for C. difficile, and they concluded that fidaxomicin was the best drug, superior to vancomycin at a horrifically more cost, and that metronidazole should never be used for C. difficile. They suggest that fidaxomicin should be first-line therapy, but remembering that most Americans, or at least 40% of Americans, can't even come up with $400 for an emergency, I doubt they're going to be paying for that drug anytime soon. But I think it's safe to say that after all the years of going back and forth as to what the best drug is for C. difficile, it's not metronidazole. A meta-analysis suggests that alcohol increases your risk for pneumonia, and the more you drink, the greater the risk for pneumonia. They say that for every 10 to 20 grams of alcohol intake per day, there's an increased risk for community-acquired pneumonia by about 8%. I'll drink to that. Alcohol's gotten a lot of bad press of late, and I just saw a patient last week who worried that he was responsible for his cancer because he liked to have a cocktail at night. But there's a choice in life between quantity and quality. I'll go with quality. Until, of course, I get my terminal illness, and then I'll backtrack so fast it will make your head spin. I usually think when a patient presents with a prolonged cough that it's going to be pertussis. This study out of Germany looked at the etiology of a prolonged cough. They found that patients ended up in the clinic at least 3 weeks after the cough started, which is way too late for antibiotics to have any effect, although 65% got antibiotics. But they did find a hodgepodge of other organisms that may or may not have been the cause of their chronic cough. And these included adenovirus, RSV, pertussis, and influenza. And if you know from other studies, the cough from influenza can last 3 or 4 weeks easy, at least when it was H1N1. My take home, though, is if someone comes in coughing of 3 weeks duration, the last thing they're going to need is an antibiotic, because whatever they had is come and gone. To my mind, cellulitis, acute febrile erythroderma, should be the simplest infection to treat. Virtually everybody needs cefazolin because it's pretty much group A strep, a couple of other streps, sometimes some staph lignonensis, sometimes some MSSA. But usually it's strep, and usually they get better on cefazolin. And people are all the time putting patients on vancomycin and Zosyn in my hospital. And it drives me nuts because it's a waste of antibiotics and it's stupid. Slowly, I'm convincing people that most people need cefazolin. And then you come up with this study. It was a comparison of IV followed by oral delafloxacin, and it was compared to vancomycin and aztreonam for an acute bacterial skin and soft tissue infection. Who the hell would give vancomycin and aztreonam for an acute cellulitis? Now, the two were equal, but when you look at the microbiology that they reported, it was the usual hodgepodge of organisms you would expect, most of which do not require vancomycin. They had MSSA, strep anginosus, strep pyogenes, strep agalactiae, staph lugdunensis. Really, all you need is cefazolin. There was a smattering of gram-negative rods, which I don't know if I believe or not, especially since they had a couple of enterococci in the group as well as staph hemolyticus. Seems that whatever they isolated, they called cellulitis. Now, I can see this paper being widely distributed by the producers of dilafloxacin, and as a consequence, people are going to be erroneously under the idea that vancomycin and aztreonam is somehow appropriate, since we're not going to have dilafloxacin on our formulary. A 20-tablet course, by the way, is $1,500. Keflex is dollars. I mean, the responsibility for antibiotic stewardship should start at the top with the clinical trials and the articles that are published in Clinical Infectious Diseases. This paper is steer manure and should never have been done, much less published, and is one of these things that is a bad influence on the approach to cellulitis in the community. People who don't know what they're doing are going to read this and prescribe inappropriately. You want to get antibiotic stewardship, CID needs to quit publishing steer manure such as this. Or if you're going to compare a new drug, you should at least compare it to a reasonable antibiotic choice for the initial treatment of a skin and soft tissue infection. Cefazolin maybe? Yeah, CID calls this a major article. Major piece of, So my take home, ignore studies like this. Jesus. And CID, they need to get a little more responsibility with their antibiotic stewardship programs. Oh yeah, and add some pronunciation guides maybe. And don't forget, with all the side effects of quinolones, they're evil. They should be avoided at all cost. As they say in the article, based on currently available data, delafloxacin does not appear to be associated with an increased risk of AE associated with other fluoroquinolones. Future observation as the drug is more widely used in the clinic would be prudent. And we know how that usually works out. God, the stuff that gets published. And if you ever wondered what killed St. John of the Cross in 1591, well, he, according to this review of his clinical course, developed cellulitis, which turned into a cutaneous abscess that went on to osteomyelitis, and he died in part because of the surgery they used to try and cure him. I always enjoy these historical analyses as to what killed famous people in the past, and it usually was an infectious disease. If only he had gotten vancomycin and aztreonam, he'd be alive today. A couple of TB studies of note. One is they looked at the response in HIV co-infected patients to tuberculosis when they had low INH and rifampin concentrations in their blood. And it did not affect the cure. They had the same success in treating patients if they had low blood concentrations, but there was a delay in culture conversion. So patients may have been infectious longer. Now combine that with another study out of the New England Journal of Medicine that showed that as the MIC to rifampin and INH went up, and mind you, it was still in the sensitive range, much like MRSA, they had a greater risk of relapse. I suppose the perfect storm would be to have someone with low blood levels of INH and rifampin and relatively higher MICs to INH and rifampin, and you may breed resistance a little faster. TB therapy has always been somewhat behind the times compared to treatment of other bacterial infections. I think knowing the MIC and measuring blood levels seems to be a lot of the time to be an important characteristics of treatment that we should be paying closer attention to. The problem, of course, being a combination of cost, technology, and habits. But in an ideal world, treating tuberculosis should be more like treating a bacterial processes where you know the MIC and you know the blood levels. For those of you that don't keep up in your cancer therapies, ibrutinib is a Bruton tyrosine kinase inhibitor that's used to treat lymphoid cancers. You see it used for CLL, Waldenstrom's, and other lymphomas, and it probably puts people at their risk for secondary infections, including bacterial infections and invasive fungal infections. And they were not neutropenic or lymphopenic. And finally, for fun, I refer you to an article in this month's Emerging Infectious Diseases entitled Emerging Infectious Literatures and the Zombie Condition, where they discuss the findings in their book club of zombie novels and how it relates to infectious diseases, microbiology, and epidemiology. They discuss one of my favorite zombie books, The Girl with All the Gifts, and a bunch of others I have yet to read. However, the article's free online at Emerging Infectious Diseases, so I recommend it for your entertainment and edumacation. And that brings us to the close of this Puscast, covering the last 2 weeks in the month of August in the year 2018. Regular listeners should know that there's going to be somewhat of a delay with the next Puscast because I'm going on a long vacation hiking the national parks of the Northwest. So I'll probably do one big one to catch up at the end of September, assuming I don't get eaten by a bear or scalded at Yellowstone. As always, references are available online, and thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along. Thank you. In dictation from a grumpy old man. Goodbye.